Good evening. I'm Dr. Phoenix Nguyen. I'm the Medical Director of Advanced Endoscopy at Hoag Hospital in Newport Beach. And I'm here to present to you non-surgical solution to GERD, which is gastroesophageal reflux disease. And I thank everyone for being here tonight, and I hope you'll enjoy our walk through this very common entity. So welcome and thank you for your attention. So the reason we are here and the reason why GERD is important is because esophageal cancer is on the rise. So if you see the graph to the right, we see increasing incidence and mortality or death related to esophageal cancer. And this is a trend that we've seen since 1975 up to the year 2001. And it really beats out other cancers, including melanoma, lung cancer. And we believe that GERD may be associated with the development of esophageal cancer. It's fairly scary because GERD is so common. So what happens in gastroesophageal reflux disease, as acid comes up into the esophagus from the stomach, it can change the inside lining of the esophagus over to what we call Barrett's esophagus. And this is a precancer condition. It's seen more commonly in the male population, Caucasian males, and it occurs over a period of years of chronic acid reflux. What happens after that typically is you'll have cancer development in the esophagus, where you have narrowing of the lumen of the esophagus and this very scary picture of a cancer associated with GERD. GERD is a fairly complex entity, and it is defined as abnormally frequent or chronic reflux. So it's the acid reflux, acid coming up from the stomach into the esophagus. And you can have typical symptoms of GERD, or you can have atypical symptoms. And some of the typical symptoms include, as you can see on the left, which is heartburn, chest pain. Patients can come into the emergency room with chest pain, and it can mimic a heart attack, but actually it's coming from acid reflux. You can have excessive salivation, regurgitation of stomach contents, and you'll have the acid taste, the burning in the back of the throat, bloating in the upper abdomen. You can have trouble sleeping because of acid reflux. It can waken the patients in the middle of the night. Sensitivity to certain foods and liquids. On the right, you'll see the atypical symptoms of GERD to include cough, sore throat, hoarseness, difficulty swallowing, asthma, COPD, and the list just goes on and on. Dental erosions, bad breath. We get quite a few consults from the dentists, from our lung physicians for these different atypical symptoms of GERD. And what happens to the anatomy that causes GERD? So up at the top of the screen, you'll see the normal anatomy. So when we eat, the food goes into this tubular structure called the esophagus, and then it goes into the stomach. Before it goes into the stomach, there's a sphincter muscle at the bottom of the esophagus. The sphincter will open when you swallow food, and then it closes back up. That's the normal anatomy and normal function of the stomach and esophagus. Okay, so at the bottom, you'll see what happens in GERD, and the anatomy is disrupted. What you'll see in patients with GERD, you can have a hiatal hernia. So a hiatal hernia is part of the stomach back up into the chest above the level of the diaphragm. Okay, so the diaphragm is what you breathe with, and it separates your chest and your abdomen. It's a set of muscles. Okay, so a hiatal hernia is part of your stomach, again, up into the chest, above the level of the diaphragm. So patients with a hiatal hernia can have GERD. Other mechanisms are at the bottom right, you'll see increased LES relaxation, which is the lower esophageal sphincter. Intermittently, it will relax. The lower esophageal sphincter, that muscle can weaken and it can shorten over time as we eat over our lifetime. The angle of His is the angle that the esophagus and the stomach forms, and in patients with GERD, that angle decreases, and the barrier to acid reflux is weakened. There are also other ligaments that hold this structure in place, and these ligaments can be broken, and the mechanism that protects against GERD can develop, can be disrupted over time, over years. So those are some of the mechanisms behind GERD, and we think now that it's a mechanical problem. It's a mechanical failure of this critical area between the esophagus and the stomach. We think now that it's actually two valves that keep us from having acid reflux. And one is the lower esophageal sphincter that we talked about, and the other is the structure in green, that's the diaphragm. So these two structures are important to maintain the acid, the stomach contents in the stomach and not in the esophagus. So when we talk about GERD, it's a spectrum disease. So you can have milder disease and you can have more severe conditions. So the milder conditions are if you have a little bit of heartburn, you take some anti-acid medication, your symptoms are controlled. The more severe conditions would be the development of inflammation in the esophagus called esophagitis, or stricturing or narrowing of the esophageal lumen, or the development, like I said before, of Barrett's esophagus and esophageal cancer. So that's the other end of the spectrum, more severe conditions. So in between, there are patients out there who have acid reflux, they have symptoms, they take the medication, somewhat controlled but not very well controlled. So spectrum disease. And when you look at the spectrum, our treatment is catered along the spectrum. So when patients have milder conditions, we intervene with more less invasive intervention. And when you have more severe conditions, we intervene more aggressively with interventions including endoscopic therapy and surgical therapy. When you look at the how common the condition is, it affects 1 in 4 people in the US. So 25%, 25 to 30% of the population have some form of GERD. And of the millions of patients out there with GERD, and they suffer, very few actually undergo a surgical intervention to treat the disease. Okay, and I think traditionally what's understood is these interventions surgically is invasive, they have high complication rates and some side effects. So we're going to hopefully talk about tonight less invasive intervention to take care of GERD, non-surgical techniques. So when you have GERD, what can you do? You can do the lifestyle modifications, you can avoid things that increase the symptoms, like avoiding foods that aggravate the symptoms, like tomatoes and citrus foods, chocolates and mints, and really everything that's good in life can increase the GERD. So you can change your lifestyle and you can modify what you eat to lessen the symptoms. Once that's been tried and you still have some symptoms of acid reflux or GERD, then we talk about medications to suppress the acid. And the anti-acid medications out there are more simple ones, over the counter. You can take the Tums, Maalox as you need it, or the next more effective medication would be the H2 blocker, like Zantac, Pepcid, Tagamet. And then the higher potency anti-acid medication are the PPIs, which are the proton pump inhibitors. which inhibits the proton pump in the stomach and decreases the acid. But you're suppressing acid, but you can still reflux, you can regurgitate, but it's just not acidic. I mentioned Zantac, but Zantac was actually taken off the shelf a few months ago. Many decades ago, the FDA approved this medication as the anti-acid medication to treat GERD, and recently it was taken off due to increased risk of cancer from our potential carcinogen that's in the drug. So that was pretty scary, pretty disappointing, because a lot of patients are on this medication chronically. When you take the PPI, some of the patients think it's very simple to do. Some patients carry it around in their purse, sometimes in their shoe. They go out drinking, they just pop a pill and they feel fine. And they really don't know, and we don't actually understand in detail the risk associated with PPI use or use of these anti-acid medications over the years. There's been many studies out there looking at associated complications from taking long-term PPI. I think the list is long, some of it is controversial. The two most believable, I think, that are somewhat supported by studies include association between PPI use and osteoporosis, and also PPI use and chronic kidney disease. So when we have a patient who has osteoporosis and need a PPI for GERD, we really need to sit and discuss with the patient the risk and benefit of taking the medication. We want to make sure that it's indicated. One recent study came out from LA, so within California, a large cohort of patients. We looked at patients on PPI chronically, and we saw an increased rate of COVID positive tests in patients who are on PPI versus those who are not on PPI. And this actually, it makes sense to us, because your stomach needs to have acid, and now you're suppressing the acid with this medication so that you don't feel the burn when the acid regurgitates into your esophagus. It's just not physiologic to take the medications on for a long time. So when we talk about Gerd therapy, we talk about taking the anti-acid medications, we talked about doing lifestyle changes so that we can improve symptoms. What is our goal? What is it that we want to do when we do therapy? So when a patient comes in, they're not happy with their medication, they have symptoms of GERD, we look at subjective improvement. What is our goal? Our goal is to control symptoms, looking at risk for osteoporosis, kidney disease development, and the use of the PPI. We look at quality of life score. How is their quality of life affected by this disease condition compared to if we put them on medication? We look at use of medication. Are they requiring daily anti-acid medication? Are they using twice a day medication, double dose, and the medication is still not working? We look at satisfaction scores. In addition to quality of life, how satisfied is the patient when they take the medication? Subjective indicators of outcome when we treat GERD is also the durability, meaning if we do something, if we intervene or we give a patient a medication, how long is it going to last? Is it going to last their lifetime? Is it going to last 5 years, 10 years? So that's an important question. When we talk about therapy, we want to look at the outcome of the therapy. So there's objective measurements of Gerd therapy as well. So when we treat a patient, we can look at a pH test. So a pH test is when we measure acid in the esophagus And we do it at baseline, and then we treat the patient, and we can follow them with a pH test. So that's more something objective that we follow the patient with after we treat or intervene. Esophagitis is another objective measure of outcome when we do treatment. And esophagitis is inflammation inside the esophagus, in the lining of the esophagus. And that irritation is because of the stomach contents. Is our therapy safe? So we want safe therapy, and we want very few side effects, right? So these are our outcome that we're looking for when we do intervention or therapy. What are the diagnostic tests prior to therapeutic interventions? So before we treat, how do we diagnose the condition? Because some of the symptoms can mimic other entities. For example, we talked about chest pain. It can mimic a heart attack. Patients with chronic cough, it can be GERD, or it could be seasonal allergies or environmental allergies that can cause the cough and mimic GERD. So initially, what we'd like to do, usually we perform an endoscopy. So an endoscopy is a small, flexible scope. It has a light at the tip. We look on the inside lining of the esophagus while the patient is sedated. And we look for complications of GERD, like esophagitis. We talked about stricturing. We talked about Barrett's esophagus. And we also look at the anatomy. Is there a Hyatt hernia? How big is it? How wide is it? So the endoscopy is an initial test, and it gives us a lot of information about what's going on in the esophagus. That pH testing is also critical. It's a diagnostic. It confirms that there is GERD, and the pH test is done best by a system we call Bravo. So the Bravo unit is a small little capsule we attach on the inside lining of the esophagus, and we have patients wear a monitor for 4 days. So during those 4 days, we ask the patient to do their usual, be normal, go out and eat a burger if they want, have a glass of wine to kind of bring on the symptoms. We don't want the patient to avoid food. We do this test off the anti-acid medication because we want to see the natural state of reflux. So it's a catheter-free. They wear a monitor that's not attached to them. We look at, during the study, when the patient has symptoms, so we can correlate the reflux event with the symptom. We look at daytime and nighttime reflux. And we also look at the eating periods, and we usually take that out of the equation. On the left, you'll see a manometry study. So the manometry study is a test to look at the function of the esophagus. So we want the motility to be normal. We want to make sure that there are not other esophageal abnormalities that can mimic GERD. For example, achalasia can mimic GERD. So we want to see if the esophagus is functioning, and we want to rule out other esophageal abnormalities with this particular test. An alternative to that manometry study, where we look at pressures, is an X-ray study. We can have patients swallow contrast and take a picture of the esophagus, and there we can look at motility. We can look for complications of GERD. So these are basic, very routinely done testing prior to any intervention. Here's an example of what the Bravo study looks like. So this is a 2-day study, and we look at upright and supine reflux. So the periods at the beginning is the daytime. There, in the second interval, there is a bold line, and that's when the patient is sleeping. So this patient has a lot of daytime reflux and no nighttime reflux. Okay. Across the middle of the screen, you'll see a line, and that line is a pH of 4. Anything less than a pH of 4 represents a reflux event. That's acid in your esophagus. And you'll see that by the second and third day, this patient has a lot of reflux events. And this study is abnormal, and it's Diagnostic of Gerd. At the bottom of that picture, you'll see that we tracked symptoms of heartburn, chest pain, and regurgitation. So all those three symptoms correlate with a reflux event. So there is symptom correlation. So we can tell the patient when they described heartburn, it exactly correlated with a reflux event. So it's very nice to look at for diagnosis and also good for symptom correlation. So what is Tiff? And I think this is the bulk of our talk tonight, is looking at a non-surgical alternative to treating patients with Gerd as the intermediate category between lifestyle modification and surgical intervention. So Tiff is transoral incisionless funapplication. So it's a non-invasive incisionless procedure. Many studies up to 10 years out have shown that this is an effective modality in the treatment of Gerd, and there's durability data up to 10 years of follow-up. We have greater than 30,000 procedures to date, and as I said, this is the treatment gap between medically refractory patients who take medication and still have symptoms, and the traditional laparoscopically done Nissen funapplication, where it's a surgical wrap. With the Nissen funapplication, the stomach is wrapped around the bottom of the esophagus to prevent reflux. Tiff is covered by public and private payers, and it's endorsed by surgical and many GI societies. Here's a brief overview of what Tiff is. Under step 1, you'll see the device, the Tiff device is placed into the stomach. So the stomach there again is below the diaphragm. And there's an endoscope within the device, and the endoscope is retroflex, or it curves so that we can look to see what we're doing. So this device is passed through the mouth. The patient is sedated. And in step 2, in the middle of the screen, you'll see that we pull the tissue down, we pull the esophageal wall or lining down, and we put in fasteners to create that tissue mold. And at step 3, you'll see that what it creates is a 3-centimeter valve, and it's a 270-degree wrap. This acts as a flap valve to prevent acid reflux. So the advantage of this valve over the traditional Nissen funapplication, which is a 360-degree wrap, is that it's just enough to prevent acid reflux, but it's not too tight that the patient will have problems swallowing. So it's the balance between just enough so that patients can still swallow, but they're not refluxing. So the clinical studies that I talked about, there are many. Initially, there were sham studies looking at Tiff versus a sham procedure. So the patient think that they're having the procedure, but they did not. And it compared, and it showed that it was effective. There were trials comparing Tiff versus medication therapy. So on the right, you'll see the study reporting up to 10-year data. So here's the evidence behind Tiff. 5 systematic reviews are out there with randomized trials that I discussed, and many cohort studies, so 140 publications with long-term follow-up. Here we looked at what we talked about before are the indicators of success of therapy. So what is the patient outcome? Here we look at quality of life measurement, and at the left of the screen is the patient's baseline, then 3 years, 5 years in follow-up. And you can see that the quality of life is improved and it stays improved. So it's not a therapy that where the symptoms will worsen over time. So this is the 5-year study. Here we look at elimination of regurgitation. So the antacid medication, as I discussed, cuts the acid and you don't feel the burn, but the food or the stomach contents can still regurgitate. So this is an indicator of elimination of regurgitation up to 5 years after the Tiff procedure. Here's the elimination of the atypical symptoms. So not the heartburn and regurgitation, but here we're talking about the atypical symptoms including cough and hoarseness, which sometimes can be quite miserable. An example of a patient's story, this is my favorite, and his wife is a yoga instructor. And his one complaint, well, he had 2 complaints. He had this jaw pain that really didn't get improved with PPI therapy. And he wanted to do yoga, and every time he's down, his head is down, he would regurgitate. Post-Tiff, he had resolution of the jaw pain, and now he's able to perform yoga with his favorite instructor. So the objective outcomes post-Tiff, here to the left you'll see the patients, the number of patients that are taken off the medications. So if you look at the many trials and many studies out there, the majority of the patients are able to get off their medication, the PPI, daily. And on the right you'll see the percentage of patients with improved esophagitis. So another objective outcome measure after Tiff. So when we talk about Tiff, the indication for Tiff is if the patient has a Hyatt hernia 2 centimeters or less, and the width of the hernia is not so wide. If the patient has a 2 centimeter Hyatt hernia or more, we would recommend a Hyatt hernia repair in conjunction with Tiff. So we would, with a robotic approach or laparoscopic, bring the stomach down below the level of the diaphragm, fix the diaphragm, and then at the same time sequentially perform Tiff. And this is the, this looks at pH, which I'm going to skip. So the concomitant Hyatt hernia repair and Tiff is what is being done currently and fairly commonly for patients with a larger Hyatt hernia. So when you look at effectiveness, we looked at heartburn improvement, regurgitation, quality of life improvement. We looked at Tiff and pH study improvement, normalization of the pH results, decreased need for PPI at 5 years, patients off PPI for the majority, and Tiff superior to PPI in eliminating regurgitation. Review of Tiff data, many meta-analysis looking at Tiff studies showing patients' elimination of PPI, significant quality of life improvement, more meta-analysis looking at Tiff compared to nascent fundoplication versus PPI. This is another patient story that is a favorite of mine. Is this gentleman, he's had Barrett's esophagus with high-grade dysplasia. So dysplasia is very close to cancer. It's the next step to cancer. And he had these nodules in the esophagus. What we've done over the years, we've removed the nodules, we've ablated the Barrett's with a technique called BARX, which is radial frequency ablation. And over a number of years, we saw that the high-grade dysplasia Barrett's esophagus persisted. He then underwent the concomitant Hyatt hernia repair and Tiff, and then we saw complete resolution of the high-grade dysplasia and his symptoms of heartburn and regurgitation. How durable is the technique? So immediately after Tiff, during the procedure, the image on the right, on the left, you'll see the scope, which is that black tubular structure. So we're retroflex, so we're in the stomach looking back up into the junction between the esophagus and the stomach. And there you see that beautiful donut-shaped 3-centimeter valve, 270-degree wrap. And this is the same patient a year out, and that almost donut-shaped structure has remained intact and looking very similar. This is what I covered before, looking at the effectiveness of a Hyatt Hernia repair, followed by Tiff. And we have excellent symptom control. The long-term data is shorter than Tiff alone, an improvement of heartburn and regurgitation with no side effects of dysphagia, which is problem swallowing, and no problem with burping or symptoms of bloating. How safe is Tiff? What are the adverse events associated with doing the Tiff procedure? Minor symptoms including chest and shoulder discomfort, a little bit of nausea, well controlled with Tylenol and anti-nausea medication. We have 4 major adverse events, but in the earlier years of esophageal perforation, we have not had any recent complication in the last 2 years. So fairly a safe procedure. To the left, we list the complications that can occur with Tiff. And on the right, you'll see that complications are very few in the later years as we develop more experience with the technique, and it's more defined, the modality in the later years. Indications for Tiff are patients with GERD symptoms despite PPI therapy, patients with the Hyatt Hernia and not so wide and not so long. However, if the patient has a larger Hyatt Hernia, we can repair the hernia and Tiff at the same time, and that also works. Patients with abnormal pH testing, like we talked about, patients with esophagitis on endoscopy, patients who take PPI for a long time and want to get off PPI because of side effects of PPI, or they're concerned with the development of cancer and precancer. Contraindications, I think these are soft contraindications. So patients with higher BMI or obesity, patients with esophageal strictures, limited neck mobility, preventing the passage of the device, prior esophageal surgery, and gastroparesis, which is abnormal emptying of the stomach. Now I'd like to share with you 2 patient stories. The first patient will describe more atypical symptoms of GERD. The patient stories are an outline of patients we have treated and giving you the spectrum. So what it was like before therapy, what it was like to undergo therapy, and then after therapy, what is life like? So I'm going to play the first video.
Well, I experienced the symptoms for 20 years, and I was on the PPIs for probably the majority of the time. Oh, I'm sorry.
No problem.
The side effects were starting to happen. Number one, I had osteoporosis coming on. I was coughing. I was, by the end, I couldn't lean back in a chair like this without having regurgitation of simple water.
Wow.
Very distressing, especially when you're out socializing with friends. I went to my specialist and I talked to him about getting off of the medication. And he was very reluctant to have me go do any type of operational procedure. So I finally convinced him to let me go talk to Dr. Nguyen, and sure enough, I went to see her. We went through all of her tests, and we decided to proceed. And I'm really glad I did, because the procedure is not difficult. I also had the hernia, which Dr. B repaired. And, but what I really, the important thing is to tell you is that getting to this point, I realized that I didn't want to suffer anymore. I didn't want to be on medication anymore. And the only way I was going to successfully be off of this is to fix it.
All right.
So I went through the surgery. The surgery was pretty easy. I felt really good the day of the surgery. A couple of days later, I'm starting to feel a little uncomfortable, but Dr. Nguyen gave me perfect instructions. She told me what to eat. She's given me a list of how soon I could transition to additional foods. So prior to the surgery, I went and I created my own diet. And I bought the foods that I could eat. And so therefore, it wasn't a stressful time to transition. And as I'm eating the foods, if I started to have symptoms again, I'd back off. And it would be almost like I'm going back a step, waiting a longer period of time, then I'm moving forward. It was not difficult for me because my goal was to fix my problem. So I didn't want to do anything to jeopardize. So I didn't do any exercising or any physical activity that could damage it. The diet wasn't bad at all. It did take 10 to 11 months before I was symptom-free.
Wow.
I have been symptom-free since then. So I am really grateful for that. I cannot stress enough how if you just are patient with regaining all of the foods that you want to eat, or all the, the choices of foods you want to eat. If you're just patient with all of this, you will experience a normal life. And I've been experiencing that now for months, and I'm very grateful.
What I love about this story is Jennifer really shows us that a symptom can be present for so many years that we don't really notice it. We just think it's part of our normal life. And patients come back to me and describe that, wow, my family now notice that I don't cough at all, and I never knew that it could be so different. I would sit in church and not a single cough coming from me, and it's such a difference, such a life change over what was baseline. Now I'd like to share with you John's story, which is a wonderful story, and John shares with us what life is like after therapy.
You know, the first symptoms were about a little over 20 years ago, manifested initially as esophageal spasms. And at first everybody thought of them. And I had all sorts of, tests done and EKGs and whatnot. And my heart was fine, and I was still having these episodes. And then it was, well, you're having panic attacks. It's too much stress in your life. So, I tried to be Zen-like and all that, and I still wasn't getting, still having them, and I was, starting to notice I was getting more and more heartburn. And then they started noticing, well, we'll start treating you for the heartburn. And it didn't make the esophageal spasms go away, but it helped with the heartburn a little bit. And it got to the point, though, where they had to refer me to a specialist for endoscopies. And it took a few years to get to that point.
Okay.
And then, I had an endoscopy. I was diagnosed with Gerd. On my first one, I was also diagnosed with Barrett's esophagus, which was scary.
Okay.
And I had endoscopies for every year, going on for a number of years, to the point where it got to where I could do them every 3 years because it was, the progress was slowing, and it was now just to make sure that everything was in check. But I was still having the spasms, and they were getting stronger and more debilitating. I even had one of those motility studies that Dr. Nguyen talked about. And I'll tell you, that is about as a medieval procedure as you can have. It was tough. It was a real tough procedure, but everything, as far as, came back, and it gave us a little bit more information. When I had my endoscopy last October, as I was meeting with the doctor beforehand to schedule it and go over, my progress and what I've been encountering, he said that there were a couple of procedures now that were available. One was the Tiff procedure, the other was the Lynx, and that, after my endoscopy, he would be able to tell me if I was a good candidate for either procedure.
Sure.
And that got me excited. And, about a week later, I had my endoscopy, and, he told me that I was a candidate. So I hit the internet and did a lot of research, a lot of reading, a lot of studying, as most people tend to do. And really, felt that the Tiffany, so I, pursued that as the course of action, and, got an appointment with Dr. Nguyen, and, went over what it was all about, got her views on it. It reinforced my, my decision that I made the right decision. And then that was in November, and then it took us, you have to get approvals, you have to do, tests. I had to go to a cardiac surgeon to make sure that, the episodes I was having, were still not, cardiac related. And on January 13th, I had my combined procedure. Dr. Perlstein came in, started off with the Da Vinci surgery, and then Dr. Nguyen came in and did the Tiff. And I think it was just, over 4 hours, between 4 and 5 hours, from when I went in to, when they brought me out to the recovery room. Have to say, well, I have to be careful. I can't say it's the best decision I made in my life, because my wife will give me a hard time. It's a health-related decision I ever made in my life. There is a very, very strict diet afterwards, and I was committed to it. I didn't want Dr. Perlstein or Dr. Nguyen to yell at me, that's for sure. But it is it's a commitment of a diet,
Right.
And it takes, 6 to 8 weeks to get through it. And I got through it. It was, parts of it were, were not fun at all, because of what you're living on for the first few days: broth, Jello, and popsicles. But a big plus, is, I lost, just over, 15 pounds, from that, which, I could use. So, but I was very, very happy with the procedure. I'm ecstatic with my quality of life now. Things that I couldn't have before. I will even take a glass of wine. I haven't been able to have wine in over, somewhere between 12 and 15 years. And I would like to toast both of my doctors, Dr. Perlstein and Dr. Nguyen. Thank you so much.
That's
The quality
fantastic.
of life is so much better. No more spasms, no heartburn, no regurgitations, no refluxes.
And no
And-
medications, right?
I'm sorry?
And no medications.
And no medications.
That was John's story. I thought it was a wonderful story to share with you tonight, and it's really amazing how different therapy can make life. So we have a few questions from the audience, and the first question that I have is, can GERD be hereditary? The statement was, my brother and father had it and passed away from it. I'm not sure whether it was from complications or cancer. And my brother had never smoked but had asthma. So yes, for sure, can be hereditary, and we usually blame our parents for everything, and this is one entity that you can blame your parents for. It can be associated with asthma or COPD. Of course, asthma can be associated with other disease conditions, and can be an underlying lung condition, not from GERD, but certainly GERD can either contribute to it or cause it. So yes, the answer is GERD is hereditary. Second question I have is, does GERD lead to more motion sickness? And are the two entities related? I will have to research this. I have not heard of GERD being associated with motion sickness, but I can answer this at a later time. What is my opinion about the Strata procedure? So Strata is using radiofrequency ablation at the lower esophageal sphincter for treatment of GERD. The data out there is more limited. We do not have it available at Hoag, but my belief is it can be used in patients with milder conditions where the anatomy is not as disrupted. And it is an option for earlier disease. And it's also an endoscopic procedure. Do we see an increased incidence or increased disease with age? I think the answer is yes, and GERD will worsen over time, usually, because the anatomy changes as we age. If there is a Hyatt Hernia, it will get larger. It will not correct itself. And usually we see patients who have been on medication for many years. Eventually the medications stop working or it's less effective. And that's because the disease or GERD has worsened over time. We have another question. Does GERD lead to esophageal cancer? And that was our first slide, and yes, we believe that it does. And I believe that it's related to the acid reflux and the irritation, and then it changes the lining of the esophagus and predisposed to precancer, Barrett's esophagus, and then eventually cancer development. That's why we care about GERD, and that's why we want to talk about GERD and see what we can do to intervene. I think I covered the questions that I have. Can we eliminate some of the symptoms by just diet change and when we eat? So I'll take the first part of this. We talked a little bit about diet and change in what we eat. Some patients are bothered with tomatoes or the wine for John, eating larger meals, more fatty meals. So yes, you can change your diet. Earlier on in the condition, you can change your lifestyle, the way you eat, the types of things that you eat, and improve your symptoms. But we notice that as the disease progresses, the lifestyle changes doesn't make much of an effect, make much of a change in the symptoms. Then the patient goes on to take medication or anti-acid medications. When we eat, does it make a difference? I think for GERD patients, having larger meals and distension of the stomach may cause more symptoms. So we encourage smaller meals and more frequent meals, and meals that are easily digested, meals that are not so fatty, and again, the different types of foods that increase the symptoms. We do not encourage eating before bedtime. Usually we wait a few hours after eating your dinner to go to bed because at nighttime, when you're flat, that's when you don't have the gravity protection, and that's when you have more acid reflux. waiting a few hours, 2-3 hours after the dinner to go to sleep. And if you're having nighttime symptoms, we encourage the head of the bed elevation so that you have a little bit of gravity protection at night as you sleep to decrease reflux. Next question is, I've had GERD for a while, but don't take medication because I don't like to. Sometimes I take Tums. Am I better off taking a PPI? I think that's a choice. It's a personal choice. I think Tums is an as-needed medication, and I think the PPI is something that is not an as-needed medication. If you choose to take the PPI, which is stronger, more effective than Tums, then you want to take the PPI on a regular basis. So daily, whether it be once a day or every 12 hours, and you want to take the PPI half an hour before a meal. That's when it's most effective. If you do take a PPI, you choose to, do not take it with an H2 blocker at the same time. So the PPI, really it's your choice. I think the side effect profile, I think it's fairly safe. Some doctors say try the PPI for a few months and then go off it and see how you do, depending on your lifestyle changes. With PPI, there's also costs associated with it. There's when you take a medication chronically, you want to remember to take the medication. So if you're doing okay on as needed Tums and symptoms are controlled, it should be fine. Okay. Thank you for all these wonderful questions. They're so good. Can the esophagus heal if reflux is eliminated? Oh, this is wonderful. Yes, I think it can. So the patient I presented to you during the slide presentation is a patient who had almost esophageal cancer. So there was Barrett's esophagus with dysplasia, and we tried every technique to get rid of it, and only after we created the fundoplication, fixed the hernia, did the dysplasia go away. So the esophagus healed, it improved after the Tiff procedure. So if you have esophagitis and you take the medication, for example, the PPI, the esophagitis can heal. So your body is amazing. It can heal. But once you develop esophageal cancer, there it's hard to treat. Esophageal cancer is one of the most lethal cancers, and it's very difficult to treat with high mortality rate and higher recurrence rates. That's what we're afraid of, and that's why we want to take care of GERD. Esophagus has amazing healing qualities besides cancer. How strict is the diet for GERD patients? Can one have tomatoes and salad dressing? Of course, sure, absolutely. And my own primary care physician, when I say, well, you know, I have this GERD and I really don't want to take medication, what do I do? And my primary care said, here's the pill, take the medication, enjoy your life, and eat what you want to eat. I'm not sure I believe in that. I agree with that. But if you want to have tomatoes and that's part of your life and part of your Italian meal, I tell patients that medications are okay to control your symptoms. I think the chronic condition, the chronic use of the medications is what I'm more concerned with. The diet for GERD patients, it depends on the severity of the condition. So like I said before in the talk, is if you have milder conditions, then you have to change your lifestyle less so than if you have more severe conditions. In the more severe conditions along the spectrum, sometimes no matter what you do, you change your life, you avoid everything that is on the list not to eat, and you still have symptoms. And at that point, the medication will control the symptoms. So the disease will progress, and how strict you are with your diet depends on where you are in the spectrum of disease. Do you have milder conditions, or do you have moderate disease, or do you have more severe conditions? Salad dressing, I think if it has tomatoes or if it's more citrus types, can worsen symptoms of GERD. What percentage of patients go from Barrett's to esophageal cancer? Actually, this is a good question, and there are a few studies out there looking at predisposition, but we know that the majority of the patients that we monitor with Barrett's esophagus don't go on to develop esophageal cancer. But we do know that when the patient comes in with esophageal cancer, then we see the background of Barrett's. Esophageal cancer is still a rare entity currently, even though we see the rising incidence. We don't know the progression of disease. We know that the majority of the patients who have Barrett's esophagus do not go on to develop esophageal cancer. However, when you do have Barrett's esophagus, we do recommend the patient stay on the proton pump inhibitor, the anti-acid medication, to suppress disease and to hopefully prevent progression of disease and progression of the Barrett's. I think that was my last question, and I thank you so much for your attention tonight. And if you have further questions, please give us a call. Again, I am at Hoag Hospital in Newport Beach, part of the gastroenterology department. And if you have any questions, please give us a call. Thank you for your attention. Good night.